Okay, let's unpack this. We're about to plunge into a problem that, frankly, keeps far too many Americans up at night. Our healthcare system. It's a striking paradox, isn't it? How can the U.S. healthcare system be the most expensive in the world, yet consistently deliver some of the worst health outcomes among high-income nations?
It's a critical question.
It really is.
Yeah.
It's a critical condition, you could say.
Yeah.
We're talking about a system where a single medical emergency can literally wipe out a family's savings.
Right.
Where prices are just a bewildering mystery, and where despite all the staggering money we pour in, things like life expectancy are actually falling.
Yeah, falling. It's hard to believe.
So for this deep dive, we've gone through a powerful report. It doesn't just diagnose these profound failures, and here's where it gets really interesting, it proposes a bold, actionable blueprint for reform. And it looks across the Pacific to Japan for a proven model.
And what's fascinating here, I think, is that the report doesn't call for a direct, wholesale copy of the Japanese system.
No, that wouldn't work.
That would be naive, right? Instead, it advocates for an intelligent adaptation. It highlights how Japan has achieved truly universal coverage, robust cost control mechanisms, and remarkably superior health outcomes. And all while preserving a robust ecosystem of private providers and offering substantial patient choice within its framework.
Private providers, patient choice. That sounds different from what some might expect.
Exactly. And this raises an important question for us in the U.S. Can America truly learn from Japan's approach and implement its core principles without becoming what some might immediately label socialized medicine?
That's the term you always hear.
It is, and it's a nuanced but crucial distinction we'll definitely need to explore today.
That's the core challenge, isn't it? So our mission today, for you listening, is to first truly understand the deep systemic problems of the U.S. healthcare system. The grim diagnosis, if you will.
Laying it bare.
Yes, laying bare why we're in this crisis. Yeah. Then we'll take you on a journey to Japan, see exactly how they managed to crack the code on healthcare, achieving those incredible outcomes for far less money, and with a surprisingly different approach than many might expect.
A very different approach.
And finally, we'll explore a detailed 4-pillar plan that suggests how the U.S. could build a hybrid system, one that's fiscally sustainable, universally accessible, and crucially delivers quality for all its citizens.
It's a potential path forward.
Get ready for some truly eye-opening insights, I think. Okay, let's start with that grim diagnosis, laid out in painstaking detail in the sources.
Yeah.
The American healthcare system, as the report describes it, is truly in critical condition. It's a multifaceted crisis, touching on cost, access, quality, and a truly staggering administrative burden that, frankly, makes little sense.
It really doesn't. And the first and perhaps most immediately shocking problem is the sheer staggering cost.
Just the numbers alone.
Exactly. The U.S. is a global outlier in what it spends on healthcare, without any commensurate benefits in terms of population health. In fact, it's quite the opposite. We pay the most to often get the least.
And the numbers are just jaw-dropping. In 2023, the U.S. spent an astounding $13,432 per person on healthcare.
Per person. $13,000.
Yeah. To put that in perspective, imagine spending twice as much on healthcare as Japan,
right,
which spent around $5,640 per person. Or consider the average of comparable wealthy countries, which is around $7,393.
So we're not just a little higher, we're dramatically higher. Double Japan, significantly more than our peers.
They're literally pouring billions more into a system that just doesn't deliver equivalent results.
And this isn't just a per capita issue, it's a fundamental economic drain on the entire nation. Health expenditures consumed 16.7% of U.S. GDP in 2023.
16.7%.
Yeah. Most peer nations, including Japan, managed to keep this figure at or below 11%.
A huge difference.
Think about that. Nearly a sixth of our entire economic output is swallowed by healthcare, a proportion that other developed nations find, well, unsustainable and unnecessary.
And here's the kicker, and this often surprises people. This isn't because Americans are getting more healthcare. The evidence actually shows similar or even lower utilization rates for key services, like physician visits and hospital stays compared to other developed countries.
Right, so it's not like we're going to the doctor twice as often.
No, we're not consuming more medical services. We're just paying a whole lot more for each one.
Precisely. The core issue, the true driver of this runaway cost crisis, is fundamentally exorbitant prices.
The prices themselves.
Yes. We pay higher prices for almost everything across the board, from physician and nurse salaries to prescription drugs that cost pennies to make but thousands to buy.
Don't even get me started on drug prices.
Oh, yeah. To individual medical services and even standard hospital procedures, this isn't a function of greater volume. It's a function of inflated prices, plain and simple.
It feels like a classic example of market failure, wouldn't you say? Forget Econ 101.
It really does.
In U.S. healthcare, competition behaves perversely. You'd think with thousands of hospitals and insurance companies, competition would drive prices down. But here, it's the exact opposite. Prices just escalate relentlessly.
Yeah, it's not working like a textbook market.
The report calls it an opaque and complex series of negotiations between powerful, consolidated hospital systems and large insurance conglomerates.
Opaque is the key word there.
It's a closed-door dance, and you, the patient, you're not invited.
That's absolutely right. And you, the listener, you're caught right in the middle, left to navigate this bewildering landscape. You're unable to get clear, upfront answers on pricing.
Never.
From either your provider or your insurer before you receive care. This information asymmetry, combined with the prevalent fee-for-service model.
Ah, fee-for-service.
Right, where doctors and hospitals are paid for each individual procedure they perform, rather than for the overall outcome. It creates what the source describes as a perverse dynamic where prices escalate without accountability.
It's like paying a mechanic for every single bolt tightened, not for actually fixing the car.
Exactly. It incentivizes more services whether you truly need them or not, driving up costs with no real check on value. It's not a true competitive market in the patient's favor. It's a system almost designed to extract maximum revenue.
And the human consequences of this financial burden are truly devastating. It's not just economic theory. It's a daily, heartbreaking crisis for millions of families.
And really is.
Nearly half of all U.S. adults find it difficult to afford their health care costs. Think about that. Almost 1 out of every 2 adults struggles just to pay for basic medical necessities.
That financial strain leads directly to what we call care avoidance.
Right, people just don't go.
Exactly. Approximately 1/3, that's 36% of U.S. adults report actively skipping or postponing necessary medical care, specifically because of the cost.
1 in 3.
And for the uninsured, that figure jumps to a staggering 75%. And the consequences are dire and entirely predictable. 18% of adults say their health worsened directly from delaying or foregoing care they couldn't afford.
So it makes things worse in the long run.
It's a vicious cycle where cost today leads to more severe illness tomorrow, which then costs even more.
And then there's the crushing medical debt. A 2022 survey found that 41% of U.S. adults, that's 2 in 5 of us,
2 in 5,
reported having debt due to medical or dental bills.
And this isn't just an uninsured problem, right?
Not at all. It impacts insured individuals, too.
Yeah.
Due to those ridiculously high deductibles and unexpected out-of-pocket costs that seem to appear out of nowhere.
Those surprise bills.
Exactly. And sadly, this burden disproportionately affects Black and Hispanic adults, highlighting existing systemic inequities and deepening economic divides.
So the system isn't just spending more, it's buying inefficiency and inequity and selling debt.
Well put. A very grim picture on the cost front.
Okay. Beyond the sheer cost, the U.S. healthcare system is also characterized by this labyrinth of access.
We remain the only high-income nation that fails to guarantee universal health coverage for its citizens. It's a glaring exception in the developed world.
It truly is. And the problem of access is a complex and fragmented patchwork, as the source vividly illustrates. In 2023, approximately 25.3 million people under 65 were uninsured.
25 million.
That's about 8% of the total population. And this isn't a random occurrence or, a lifestyle choice for most people.
No.
It's a systemic failure. It's a direct consequence of policy choices and a market-driven approach that simply leaves millions behind.
And what's crucial here, and this often debunks a really common myth.
Yeah.
Many people assume the uninsured are primarily unemployed or just not working, but the data tells a profoundly different story.
What does it show?
The vast majority of the uninsured, 73.7% in 2023, are actually in families with at least one full-time worker.
Wow, nearly 3/4.
So having a job for millions of Americans does not guarantee access to affordable health care. The primary reason people remain uninsured isn't a lack of effort. It's simply unaffordability.
That's a critical point. And we also see stark disparities in who remains uninsured, which only exacerbate existing social inequalities.
How so?
Well, people of color account for 60.4% of the uninsured population, despite making up only about 38.7% of the total population.
That's a huge overrepresentation.
It is. For example, the uninsured rate for Hispanic individuals was 17.9%, and for American Indian Alaska Native people, it was 18.7%. That's nearly 3 times the 6.5% rate for white people.
3 times.
These figures aren't just statistics, they represent profound inequities in health opportunities and outcomes, where access to care is often determined by race and socioeconomic status.
And the report points out that the persistence of this large uninsured population isn't some intractable, inevitable problem, right?
Not at all. It's a direct consequence of very specific policy choices.
Like the Medicaid expansion decision under the ACA?
Exactly. That's the most vivid example, which still frustrates so many. The Affordable Care Act offered states significant federal funding, 90% to 100% of the cost to expand Medicaid, covering nearly all low-income adults.
A great deal, financially.
A fantastic deal. Yet, as of 2024, 10 states have stubbornly refused to do so.
10 states still holding out.
Yes. And this refusal has created what's famously or infamously known as the coverage gap.
Explain that gap again.
It leaves an estimated 1.5 million adults in an impossible situation. They earn too much to qualify for their state's existing, more restrictive Medicaid program, but too little to receive subsidies for private insurance on the ACA marketplaces.
So they're trapped. No affordable options.
Literally trapped in a bureaucratic no man's land. And if we connect this to the bigger picture, the impact of these policy choices is undeniable. In 2023, the uninsured rate in non-expansion states was 14.1%.
15%?
Nearly double the 7.6% rate in expansion states.
Wow, double. That's stark.
It is stark. And this divergence really proves that lack of access isn't intractable. It's a solvable problem, squarely tied to political will and specific legislative decisions.
And countries like Japan show it's possible.
Absolutely. Japan made universal coverage a legal and social mandate way back in 1961. They clearly demonstrate that achieving 100% coverage is entirely possible when it's prioritized as a national goal. It's a matter of policy, not destiny.
Which brings us to the paradox of quality. This is fascinating. The U.S. healthcare system is a study in sharp contrasts. We are global leaders in some highly specialized areas, yet a catastrophic failure in broad population health outcomes. It's like we have Rolls-Royce parts, but the car itself is constantly sputtering.
That's a good analogy. On one hand, the U.S. certainly has strengths, and it's important to acknowledge them.
Okay.
It ranks high in care process metrics, which measure the delivery of preventative services like mammograms and flea shots, patient engagement, safety protocols.
So the processes can be good.
Yes. And of course, the U.S. is an undisputed engine of medical innovation, leading the world in developing new drugs and cutting-edge medical devices.
Right, the innovation piece.
And this technological prowess does translate into strong performance in certain acute care settings. For example, our 30-day mortality rates after heart attacks or strokes are similar to or even better than those in peer nations.
So if you have a heart attack and get to the right hospital quickly,
the care can indeed be world-class.
But, and this is the crushing but, despite these pockets of excellence, the aggregate health outcomes for the American population are abysmal.
Yeah, the overall picture is grim.
We consistently rank at or near the bottom among high-income countries. Life expectancy in the U.S. has not only stagnated but actually fallen in recent years, creating a staggering gap with our peers. In 2022, U.S. life expectancy was 77.5 years. That's nearly 5 years shorter than the 82.2-year average in comparable countries.
5 years less life, on average.
And Japan, by contrast.
Japan boasts one of the longest life expectancies in the world, at 84.5 years.
Wow, that's a 7-year difference. A full 7 years of life, on average, lost to systemic failures here.
And this mortality gap is driven by alarmingly higher rates of death from preventable causes.
Preventable deaths.
Yes. The U.S. has the highest rate of preventable death and the highest overall disease burden among its peers. Perhaps the most shocking illustration of this underperformance, as the source points out, is in maternal and infant health.
Oh, this is terrible.
An area where wealthy nations should excel.
Oh, yeah.
The U.S. maternal mortality rate is, quite frankly, a national disgrace.
What are the numbers?
It stood at 22.3 deaths per 100,000 live births in 2022.
22.3.
This is more than 5 times higher than the comparable country average of 3.9 and wildly higher than Japan's rate of 4.3.
5 times higher. It's unbelievable.
It's a reflection of a system that fails its most vulnerable populations at the most critical times.
So, when you look at these outcomes, what's the fundamental flaw in our approach to quality? Are we just brilliant at putting out fires, but terrible at preventing them from starting?
I think that captures it well.
It seems our system is optimized for high cost, technologically intensive rescue care. Yet it systemically fails at the continuous, preventive, population-wide health management that truly generates good health.
That's precisely it. And this failure directly stems from the cost and access issues we just discussed.
It all connects back.
Absolutely. When millions are uninsured or avoid care due to cost, they don't receive the consistent primary and preventive care needed to manage chronic conditions early.
Right. Things get worse.
These conditions then progress untreated, often spiraling until they become acute emergencies, requiring the expensive rescue interventions at which our system, ironically, excels.
The expensive part we're good at.
Right. Japan's model, with its pervasive universal access and strong emphasis on prevention woven throughout the system, clearly breaks this cycle. They achieve better outcomes for less money by investing in health upfront, rather than just treating sickness at the last minute.
Investing in health, not just sickness care.
Okay.
And finally, the fourth horseman here, the burden of bureaucracy.
Oh, the paperwork.
Many consider this the single largest source of waste in American healthcare. This administrative complexity is immense, uniquely burdensome, and truly mind-boggling when you look at how other nations manage it.
It's an astonishing drain on resources. The U.S. spends an estimated $1.1 trillion annually on healthcare administration.
$1 trillion on admin.
Yes, with over $500 billion of that considered excess when compared to a more streamlined system like Canada's.
$500 billion wasted.
To put that in perspective, on a per capita basis, we spent $925 per person on administration in 2021. That's nearly 4 times the $245 average of comparable countries.
4 times the admin cost per person.
This administrative bloat accounts for approximately 8% of our total national health expenditures, dwarfing the 1% to 3% share seen in other high-income nations.
So 8% here versus maybe 2% elsewhere.
Exactly. It's literally money burned on paperwork instead of patient care.
This waste, as the source describes, it's a self-inflicted wound, right? Stemming directly from the system's inherent fragmentation.
Completely self-inflicted.
It's a direct consequence of having thousands of different public and private insurance plans, all with their own rules and forms.
Exactly. Each plan has its own unique set of benefits, its own provider networks, its own co-payment structures, baffling referral requirements, endless prior authorization rules.
It's a nightmare just listing it.
It is. Analysts describe this as both contractual complexity, the bewildering variety of individual insurance contracts, and architectural complexity, the pervasive lack of standardization across the entire market.
Imagine trying to run a business where every customer had a completely different payment system.
That's essentially what healthcare providers face daily.
And the impact is felt everywhere, by everyone. Providers, from small clinics to large hospitals, are forced to employ legions of billing and administrative staff.
Armies of them.
Whose sole job is to navigate this maze, submit claims to hundreds of different payers, and literally fight for reimbursement.
It diverts crucial resources and focus away from actual patient care, forcing doctors and nurses to spend less time with patients and more time on paperwork.
Less time healing, more time billing.
Precisely. And for patients, it's a constant source of frustration and confusion. Think about it.
Oh, I know it.
Duplicative intake forms at every new appointment, bewildering bills from multiple entities for a single episode of care, opaque explanations of benefits that no one can understand, and frequent claim denials requiring time-consuming appeals.
It's truly a nightmare designed to wear you down.
It is. And this raises an important question. Is this complexity inherent to medicine itself?
I doubt it.
No, it's inherent to the American method of financing it. Every dollar spent on duplicative paperwork, complex billing software, and claim adjudication is a dollar that cannot be spent on patient care, medical research, or public health initiatives.
So much potential wasted.
The administrative simplicity of a system like Japan's, with its uniform national fee schedule and standardized benefit packages, represents the single greatest potential source of efficiency gains and cost savings. To solve the problem of administrative waste, one must address the fundamental design of the financing structure itself. It's not about finding a better paperclip, it's about eliminating the paper entirely.
Right, redesigning the whole process. Okay, so after that rather sobering diagnosis of the U.S. system...
Deep breath.
Deep breath. Let's pivot and examine Japan's healthcare model. The report describes it as a compelling alternative and a study in controlled universality. And crucially, it's important to understand it's not socialized medicine in the way many Americans might conceive it, all right? Not government owning everything.
That's a key distinction. It's not that at all. It's a dynamic, universal social insurance system with plenty of private involvement.
Okay, so what's the foundation?
The bedrock of the Japanese system is universal, mandatory coverage, a principle established way back in 1961.
Since 61, wow.
Yes. Every resident of Japan is required by law to be enrolled in a health insurance plan. This isn't about individual choice between wildly different, confusing plans like in the US.
No shopping around endlessly.
No. Plan enrollment is automatically determined by your employment status, age, and place of residence, ensuring absolutely no one falls through the cracks. It's a fundamental commitment to social solidarity.
Okay, mandatory universal. But you said it's not single payer? That's a common misconception.
It is a common misconception. It's actually a regulated multi-payer system with over 3,000 distinct nonprofit insurance funds.
3,000 funds. How does that work together seamlessly?
It sounds complex, but they operate through three major interconnected schemes working in concert.
Okay, what are they?
First, you have employees' health insurance, or Easy Aishai. This covers the working population employees of medium to large corporations, public sector workers, private school teachers.
So most workers.
Right. It's quite fragmented on the surface, with over 1,400 different insurance societies, often managed by individual large companies. However, for smaller businesses, there's a single government-managed EHI plan that fills the gap.
Okay, so big companies might have their own society. Small businesses go into a government-managed one. What about everyone else? The freelancers, students, people between jobs.
That's where the National Health Insurance, or NHI, comes in. This acts as a comprehensive catch-all.
A safety net.
Exactly. Covering the self-employed, students, freelancers, the unemployed, and retirees under the age of 75. NHI is administered at the local level by Japan's 47 prefectures and their municipalities, ensuring local accountability.
Okay, and the elderly, over 75.
Since 2008, there is a distinct nationally unified health insurance for the elderly scheme, specifically for residents age 75 and over.
A dedicated plan for them.
Yes. This was a smart move to manage and transparently address the high costs associated with this demographic, recognizing the major demographic shift Japan is experiencing.
That makes sense. That's a remarkably comprehensive and layered structure.
Right.
So how is it financed? Is it all through taxes or?
Not entirely through taxes. It's a clear model of shared responsibility. For EHI, employers and employees typically split the premium cost, each contributing approximately 5% of the employee's salary.
10% each, based on salary. Predictable.
Very predictable. For NHI, premiums are calculated based on household income, assets, and family size, ensuring it's affordable and equitable for everyone, from a struggling student to a successful entrepreneur.
So it's adjusted based on ability to pay. What about when you actually go to the doctor? What does a patient pay at the point of service? Are there high deductibles like here?
No, none of those confusing high deductibles. The system uses straightforward co-payments.
Okay.
For most working-age adults, it's a standard 30% co-payment for care, whether it's a doctor's visit or procedure.
30% flat rate.
Generally, yes. This rate is lower for young children at 20%, and for the elderly, it's 10% or 20% depending on their income.
Lower for kids and seniors.
Right. There are no complex deductibles to meet before coverage kicks in, no complex coinsurance percentages to calculate. And crucially, the government provides significant financial support through general tax revenues.
Ah, so taxes play a role.
Yes, especially for the NHI and elderly schemes, which tend to have more lower income and higher cost individuals. This ensures the system's stability and equitability.
Okay, let's unpack this. This is often the game changer for many Americans. The concept of catastrophic coverage. We hear horror stories here about medical bankruptcies that can wipe out generations of savings. How does Japan prevent that?
This is truly one of the most remarkable features and, as you say, a fundamental architectural difference from what you experience in the U.S.
What is it?
Japan's system includes a monthly out-of-pocket maximum.
A monthly cap.
Yes. Once a household's total co-payments in a given month reach a set threshold, which varies by income and age, all further costs for that month are covered entirely.
So you know the absolute maximum you could possibly pay in a bad month.
Exactly. For a typical working-age person, this cap is around $90,000, which is approximately $724 today.
Around $700-ish.
So regardless of how catastrophic your illness, maybe needing intensive surgery or cancer treatment, you know the absolute maximum you'll pay out of pocket in any given month.
That protection seems huge.
It is. This feature effectively eliminates the risk of medical bankruptcy that is so prevalent in the United States, providing an unparalleled level of financial security. Imagine a system where your maximum out-of-pocket for the month is capped, protecting you from financial ruin, and it's built on a foundation of social solidarity. That's a profound promise.
It's clear that the foundational structure is vastly different. The sources provide a useful table highlighting these fundamental architectural differences.
Yeah, the comparison is stark.
In the U.S., coverage is a patchwork, often voluntary, precariously tied to employment. In Japan,
Universal, mandatory, and a statutory social insurance right for every citizen.
and the role of private insurers.
Fundamentally different. In the U.S., they are primary risk bearers, for-profit entities offering varied, complex plans designed to maximize profit. In Japan, they function as nonprofit administrators of statutory plans with uniform benefits.
So they manage the system, not gamble on your health.
Precisely. This shifts their incentive from profit to efficiency and service.
And the price-setting mechanism.
Night and day, right?
Absolutely night and day.
Yeah.
In the U.S., it's private, opaque negotiations between thousands of payers and providers, leading to thousands of different fee schedules and extreme, unpredictable price variation.
And in Japan?
It's a single, uniform national fee schedule negotiated by a central council, one price for everyone.
Which leads to huge differences in patient cost sharing.
Definitely. In the U.S., you're looking at high deductibles, varied copays, complex coinsurance, constant uncertainty. In Japan, it's standardized copayments, typically 30%, but with those crucial monthly out-of-pocket caps.
Preventing financial ruin. Yes, and the administrative structure reflects this. The U.S. is highly decentralized, burdened by complex billing, thousands of forms. Japan uses centralized claims, clearinghouses, and standardized procedures designed for efficiency.
It really highlights that Japan's success isn't minor policy tweaks. It's a fundamentally different philosophy.
A different philosophy of healthcare financing that prioritizes stability, equity, and predictable cost over a chaotic, profit-driven market.
So let's talk more about that single, uniform national fee schedule. The report emphasizes this as the engine of cost control. How does this powerful tool actually work?
This is truly the most important mechanism underpinning Japan's remarkable ability to control healthcare costs while ensuring quality.
The linchpin.
You could say that. This powerful tool gives the government direct leverage over the price of nearly every medical service, procedure, and prescription drug delivered in the country. It's the engine that drives the system's financial stability and predictability.
Allowing for planning, not just reacting.
Exactly. Long-term planning and investment rather than simply reacting to spiraling costs like we often do here.
And it's not a static list of prices that just gets set once and forgotten, is it?
No, definitely not. It's a dynamic, living policy instrument that is meticulously reviewed and revised every 2 years by the Ministry of Health, Labor, and Welfare.
Every 2 years.
Yes. The key negotiations happen within an incredibly important body called the Central Social Insurance Medical Council, known as CHUKIO.
CHUKIO.
This is an advisory body, but a very influential one, composed of representatives from all major stakeholder groups.
Like who?
Payers like insurers and employers, providers like the Japan Medical Association and hospital associations, and crucially, the public, ensuring a balanced perspective.
So it's a collaborative, transparent negotiation, not just the government dictating prices.
Yeah, precisely. The process operates on 2 levels. First, at the macro level, the government, in consultation with the Ministry of Finance, determines the global revision rate.
The big picture target.
Exactly. This sets the target for the overall increase or decrease in national health spending for the next 2-year cycle. This macro target is a crucial lever for fiscal control.
And then the micro level.
Then at the micro level, CHUKIO dives into detailed line-item negotiations to adjust the prices for thousands of individual services and products to meet that global target.
Ah, so they can be strategic.
Highly strategic. If, for instance, a particular procedure is being overutilized, the council can lower its reimbursement fee to disincentivize its use.
Makes sense.
Or, conversely, increase reimbursement for underutilized but important services like primary care.
Like that example in 2002 where they actually cut the reimbursement fee for an MRI scan by a significant 35% because they were concerned about overuse.
Right. They saw potential overuse and acted decisively using the fee schedule. That's real power to shape care patterns.
That direct ability to manage both aggregate spending and specific utilization patterns is a capability the U.S. system completely lacks, isn't it?
Completely lacking, to our detriment. The impact of this national fee schedule is profound.
How so?
It completely eliminates the wild price variation and opaque billing that characterize the U.S. system. A hospital in bustling Tokyo receives the exact same payment for a given procedure as a clinic in a quiet rural village.
Same price everywhere.
Yes. It ends the practice of cost shifting, where providers overcharge private insurers, to make up for low government reimbursement rates.
Which drives up our premiums.
Exactly. It means your private insurance premiums aren't effectively subsidizing lower payments from government programs. Most importantly, it provides that powerful, centralized lever for controlling the nation's overall healthcare expenditure.
Okay, so with all these remarkable strengths, universal coverage, strong cost control, high quality, what are the trade-offs or weaknesses of the Japanese model? No system is perfect, right?
That's absolutely true. While Japan consistently boasts excellent health outcomes at a moderate, sustainable cost.
Top life expectancy, reasonable spending.
Right, well, in line with OECD averages, far below the US, and truly excels in equity and access, one frequently cited historical weakness has been the traditional lack of a formal gatekeeper system.
No gatekeeper. Meaning?
Unlike countries with strong general practitioner networks, patients in Japan have historically had the freedom to go directly to any specialist they choose without a referral.
Which sounds like ultimate patient autonomy and may be appealing to many Americans.
It does sound appealing on the surface.
But I can see how that might lead to inefficiencies or fragmented care. Maybe seeing a specialist for something a primary care doc could handle easily.
It absolutely can. It potentially leads to the overuse of expensive specialist care for minor ailments and also to the overcrowding of hospital outpatient departments with non-urgent cases.
So people showing up at the big hospital ER for a cold?
Potentially, or just overwhelming outpatient specialist clinics. However, the system has demonstrated its adaptability. Recognizing this issue, it introduced what's been termed a soft gatekeeper mechanism.
A soft gatekeeper. How does that work?
To gently discourage inappropriate use of large hospitals, patients who visit a major hospital for the first time without a referral from a local clinic are required to pay an additional, non-reimbursable fee for treatment of patient's choice.
Ah, an extra fee if you bypass the local clinic.
Exactly. It's typically a few thousand yen, so not prohibitive, but enough to make you think twice.
A financial nudge.
Precisely. It creates a subtle financial incentive for patients to first seek care at a local clinic, rationalizing the flow without strictly limiting their freedom of choice. It's a clever nudge, not a hard barrier.
As a clever way to guide behavior without imposing rigid restrictions.
What's the biggest long-term challenge for Japan, then, given its unique demographics?
Yeah, the demographics are key. The most significant long-term challenge is the immense fiscal pressure from its rapidly aging population.
One of the oldest populations in the world.
Exactly. A significant proportion of its citizens over 65, and that number is growing fast. This demographic shift leads to a continuous rise in healthcare costs driven by the intensive needs of the elderly. So managing those costs is the big test.
Managing these rising costs while maintaining universal access and high quality is their central task for the coming decades. But what's fascinating here is how Japan manages its market even with these pressures.
How so?
With fixed prices and standardized benefits, providers are forced to compete on what truly matters to patients: quality of care, patient experience, accessibility, and reputation.
Competing on quality, not price games.
Right. This is a more rational and patient-centric form of competition, and it offers a powerful lesson for us. The nuanced design of that referral fee further illustrates the sophistication, using a gentle market-like signal, a price nudge, to guide patient behavior toward more efficient care pathways, rather than imposing a restrictive mandate. It's a system that understands market forces, but harnesses them for public good.
Harnessing market forces, not just being ruled by them. Okay, so we've diagnosed the critical condition of U.S. healthcare and taken a deep dive into how Japan successfully manages its system. Now let's transition to the exciting part.
The blueprint.
Yes, a concrete four-pillar blueprint for U.S. reform, adapting these proven principles to our unique American context. The report clearly links each proposed pillar back to a U.S. problem and its Japanese analog, making it a truly evidence-based path forward.
And again, this blueprint is absolutely not about a direct copy.
Right, adaptation, not duplication.
But about intelligent, context-aware adaptation. The first and most essential step, the foundation upon which everything else rests, is establishing universal, mandatory coverage.
Pillar 1, universal coverage.
Yes, this directly addresses the acute problem of our 25 million plus uninsured, the lingering coverage gaps, and the profound inequities in access we discussed earlier.
And the Japanese analog is clear.
Of course, their statutory health insurance system, which has had mandatory universal coverage for over 60 years, proving its feasibility and durability.
So how would this work in the U.S.? The report suggests not a single government plan, but a regulated two-tiered framework. Tell us more about the proposed employer-sponsored insurance, or ESI reform, since that's currently the backbone for so many Americans.
Right. It acknowledges the reality of ESI. The report proposes preserving ESI for medium and large companies, but fundamentally transforming it from its current chaotic form.
Transforming how?
Private insurance companies would continue to operate these plans, but their role would shift dramatically. They would no longer be risk-bearing entities competing on complex, opaque benefit designs or by trying to avoid sick patients.
So they wouldn't be trying to cherry-pick healthy people.
Exactly. Instead, they would function as non-profit, regulated administrators, much like the health insurance societies in Japan's EHI scheme.
Administrators, not risk-takers.
Yes. They would be required to offer a federally defined, standardized, and comprehensive benefit package, the same package for everyone covered through ESI.
One standard plan.
Yes. Their role would shift from designing and marketing confusing duplicative products to efficiently managing enrollment, processing claims, and providing excellent customer service for a uniform, comprehensive plan. It leverages existing infrastructure while fundamentally removing perverse incentives and ensuring fairness.
Okay, that covers people with jobs at medium-large companies. What about everyone else? The self-employed, unemployed, small business employees, students, the millions who currently fall through the cracks or struggle with marketplace plans.
For them, the blueprint proposes the creation of a new public health insurance program, the American Health Insurance, or AHI program.
Okay.
This would be modeled on Japan's national health insurance and administered at the state or regional level, allowing for some local flexibility.
State or regional administration.
And the benefits.
Crucially, the AHI program would offer the same standardized benefit package as the reformed ESI plans.
Same benefits for everyone, regardless of how they get coverage.
Exactly. Ensuring uniformity of care across the entire system, regardless of your employment status. It would also absorb all individuals currently eligible for Medicaid, as well as those struggling in the ACA marketplaces.
So it fixes the Medicaid gap.
Completely eliminating the painful Medicaid coverage gap that currently leaves millions of poor adults uninsured in non-expansion states. That alone would be huge. How would enrollment work? People wouldn't have to sign up themselves.
The proposal suggests automatic enrollment, facilitated seamlessly through the tax system or other government agencies, ensuring truly universal coverage from birth.
Automatic, no one left out.
That's the goal. Premiums would be income-based, similar to how Social Security or Medicare taxes are structured, with generous federal and state subsidies ensuring affordability for all, especially low-income households.
So ability to pay is built in.
Yes. Imagine a system where you are automatically covered with a comprehensive set of benefits, regardless of your job status or income, and those infamous coverage gaps simply cease to exist. That's the core promise of this pillar. A foundational right to health security for every American.
Universal coverage sounds like an absolute must, but as we noted earlier, it alone can't solve our fundamental cost crisis. That leads us directly to Pillar 2.
The price problem.
Right. Taming prices through national fee regulation. This directly addresses our runaway prices for drugs, services, labor, taking bold inspiration from Japan's highly effective national fee schedule and the Chuikyo Council.
Exactly. This pillar calls for the establishment of an independent quasi-governmental body, the American Health Payments Council, or AHPC.
AHPC, got it.
The AHPC would be structured similarly to Japan's Chuikyo, with a board composed of representatives from all key stakeholder groups.
Patients, doctors, hospitals, employers, pharma, government, everyone at the table.
Everyone at the table. This inclusive multi-stakeholder structure is absolutely vital for legitimacy, buy-in, and ensuring that diverse perspectives are heard in setting prices.
And its primary and most impactful function. What would the AHPC actually do?
Its primary function would be to negotiate and publish a single national fee schedule.
One price list for the whole country.
Yes. This schedule would establish a uniform price for every medical service, procedure, and prescription drug, effectively ending the Wild West of healthcare pricing.
And this would apply to everyone, all insurers.
Critically, yes. This fee schedule would be legally binding on all payers in the system, both the reformed ESI plans and the new AHI program. This single all-payer rate-setting system would fundamentally rewire the financial incentives of American healthcare.
Rewire the whole system.
It would bring transparency and predictability where currently there is only chaos.
Here's where it gets really interesting, I think. If everyone knows the price for a procedure is the same everywhere, the mystery, the ability to wildly overcharge those surprise bills, they just vanish.
That's the idea. It would immediately end the chaotic price variation and obscurity that currently define our market, where a knee surgery can cost $10,000 in one hospital and $50,000 across the street.
That has to stop.
It would eliminate the ability of providers to cost shift by charging private plans more to compensate for lower public rates, which, as we discussed, ultimately pushes up your private insurance premiums.
So it stops that hidden subsidy.
Exactly. Most importantly, it would directly attack the root cause of the U.S. cost crisis, exorbitant prices. By giving the AHPC the authority to negotiate drug prices and adjust reimbursement rates based on value and actual cost, this pillar introduces the rational, centralized cost containment power that has been the key to Japan's success.
That negotiation power, especially for drugs, is something the U.S. government currently lacks in many ways.
Precisely. This single all-payer rate-setting system is the direct, powerful answer to our biggest problem: what things cost. It injects true market logic into the system, but on the side of the patient and the payer, not just the provider maximizing revenue.
Okay, Pillar 1, universal coverage. Pillar 2, national fee regulation. Which brings us to Pillar 3, radical administrative simplification.
Tackling the bureaucracy.
Yes, this directly addresses that extreme administrative waste and complexity that plagues our system, drawing on Japan's highly efficient standardized benefits and centralized claims processing system.
And one of the most immediate and profound benefits of implementing the first two pillars is the automatic simplification of the system's crushing administrative burden.
How so? Does it just happen?
In large part, yes. The immense complexity that generates hundreds of billions of dollars in waste is a direct function of the thousands of different benefit packages and the countless different fee schedules in the current system.
Right, the variety is the problem.
Think of it. Doctors' offices today need to understand literally thousands of different rules for billing and reimbursement. By mandating a standardized benefit package under Pillar 1 and a uniform national fee schedule under Pillar 2, this reform plan inherently eliminates the root cause of that complexity.
So the mountains of paperwork and the legions of billing staff just naturally disappear or drastically reduced, fewer phone calls fighting with insurers.
To a very large extent, yes. When every insurer covers the same set of services and every provider is paid the same amount for those services, the need for vast administrative armies to manage bespoke contracts, adjudicate complex claims, and navigate endless prior authorizations largely disappears.
That sounds almost too good to be true for doctors' offices.
This natural simplification would be further enhanced by the creation of a centralized claims processing system modeled on the efficient administrative clearinghouses in Japan.
A central clearinghouse.
Yes. A single national or streamlined network of regional clearinghouses would be established, acting as a universal intermediary for claims.
And how would that work for providers on the ground, the doctors and hospitals? How would they get paid?
It would be much simpler. Under this new system, a provider would submit a single, standardized electronic claim for a patient, regardless of whether that patient is covered by a reformed ESI plan or the AHI program.
One form, one process.
Exactly. The clearinghouse would instantly verify the claim against the national fee schedule and direct the payment from the appropriate insurer. This process would slash the billing-related overhead that currently consumes a massive portion of provider resources.
Imagine being a doctor, dedicating your life to healing, and spending half your day battling insurance forms. This system frees them up.
That's the goal. Frees them to focus on your care, not bureaucracy. The projected savings from this radical simplification are enormous.
I'm sure talking.
Economic models consistently identify administrative efficiency as the largest single source of savings, potentially freeing up hundreds of billions of dollars annually.
Hundreds of billions? Just from simplification?
Yes. And if we connect this to the bigger picture, this isn't just about saving money, it's about freeing up physicians and their staff from mountains of paperwork, allowing them to focus on your care, not bureaucracy. It's a fundamental shift in how time and resources are allocated in the system.
Redirecting from waste to care.
Precisely. Redirecting them from waste to actual patient benefit. These freed-up funds could then be reinvested to improve patient care, enhance provider compensation, or lower the overall cost of the system for taxpayers and employers.
Okay, that's 3 pillars. Finally, we have Pillar 4, reorienting care delivery and strengthening primary care.
A critical piece.
This addresses our weak primary care infrastructure and often inefficient specialist use, learning from Japan's soft gatekeepers, but importantly, improving upon it and strengthening it for the unique U.S. context.
Yes, this is a critical area where the U.S. cannot simply copy the Japanese model, but must actively and strategically improve upon it.
Why improve? Doesn't Japan do well?
While Japan achieves excellent outcomes, its system has been criticized, as we noted, for a relative weakness in primary care coordination and the potential for inefficient overcast of specialists. The U.S. suffers from a similar, though far more severe, lack of a strong primary care foundation.
So we need to build that foundation stronger here.
Absolutely. This pillar proposes implementing a strong, soft gatekeeper model, combining the freedom of choice found in the Japanese system with powerful incentives to encourage the rational, efficient use of care.
A strong, soft gatekeeper. Okay, how would this incentivize patients to engage with primary care without feeling like their choices are being dictated?
Upon enrollment in the new system, every resident would be strongly encouraged to designate a primary care provider, or PCP.
Designate a PCP.
To incentivize and solidify this crucial relationship, all visits and preventive services with your designated PCP would have a zero copayment.
Free primary care visits.
Essentially, yes. Removing any financial barrier whatsoever to establishing a medical home and receiving continuous preventive care, addressing that tendency to avoid care due to cost.
That's a big incentive. What about seeing specialists?
Patients would still retain the freedom to see a specialist without a referral, preserving that autonomy.
Still have choice.
Yes, but doing so would incur a significant, though affordable, fixed copayment, for example, maybe $100 to $200.
So a noticeable cost if you bypass the PCP.
Right. This directly adapts Japan's fee for treatment of patient's choice, but with a more pronounced nudge. However, and this is key, if a patient receives a referral from their PCP to see a specialist, the copayment for that specialist visit would be completely waived.
So get the referral, specialist visit is covered without the extra copay.
Exactly. This preserves your autonomy while creating a clear financial nudge to coordinate your care through a primary care physician, ensuring specialist visits are truly necessary and appropriately timed, improving overall care coordination.
That makes sense. It guides but doesn't restrict. And for providers, how do we fix the critical national PCP shortage and make primary care an attractive career choice again? Because right now it often feels undervalued compared to specialties.
That's a huge piece of the puzzle, you're right. The American Health Payments Council, the AHPC from Pillar 2, would be explicitly tasked with recalibrating the national fee schedule.
Using the fee schedule again.
Yes, using that powerful tool to correct the historical undervaluation of primary care.
Meaning paying PCPs more for their time and expertise.
Exactly. Reimbursement rates for cognitive and management services, the core of what primary care physicians do, the thinking, the listening, the coordinating, would be significantly increased relative to procedural and specialist interventions.
So valuing the thinking as much as the doing.
Well put. The goal here is twofold. To make primary care a more financially attractive and sustainable career path, helping to address the national PCP shortage by drawing more talent into it.
We desperately need more PCPs.
And ensuring the delivery system is built on that strong preventive foundation. It's about valuing the holistic health of a patient, not just treating symptoms in isolation.
Okay, so we have this technically sound plan with 4 interconnected pillars: universal coverage, national fee setting, administrative simplification, and strengthening primary care. It sounds transformative.
It would be.
But as the report emphasizes, that's only step 1. The history of U.S. healthcare reform is complex, fraught with political, economic, and cultural barriers. How do we even begin to navigate this transition? This is where the rubber meets the road, right?
Absolutely. Any attempt at fundamental healthcare reform in the United States will inevitably face intense, well-funded opposition from powerful incumbent interest groups that benefit immensely from the status quo.
Usual suspects.
You know them. Historically, organizations like the American Medical Association, the private health insurance industry, pharmaceutical companies, they've successfully defeated reform efforts by mobilizing considerable financial and lobbying resources.
And they frame it negatively.
They often frame these proposals as socialized medicine or a direct threat to American freedoms and choice. And the deep political polarization of our modern era further complicates this, making consensus incredibly difficult.
So what's the strategy for overcoming this entrenched resistance beyond just having a good plan on paper?
It requires a sophisticated strategy of proactive coalition building and meticulous public framing. Many past reform efforts failed because they were perceived as top-down or too ideological.
Right.
A successful campaign for this kind of reform must unite a genuinely diverse, broad coalition.
Who needs to be in that coalition?
patient advocacy groups who desperately want relief from debt and lack of access, labor unions fighting for better benefits, small and large businesses who are burdened by ever-increasing healthcare costs.
Businesses are key.
Absolutely. And crucially, a growing number of physicians and nurses who are frustrated with the current administrative waste and want to focus on patient care.
Bringing everyone together, and the framing, as the report highlights, is absolutely key. How do you neutralize predictable attacks, particularly that socialized medicine label?
It's critical. First, you have to explicitly and repeatedly emphasize this is not single payer.
Hammer that point home.
Yes. The proposed model is a regulated multi-payer social insurance system. It is explicitly not a government-run single-payer system like the UK's NHS or proposals often labeled Medicare for All.
How does it differ?
The plan preserves a significant role for private insurers as plan administrators and maintains a system of private, independent providers. This distinction is vital to diffuse the socialized medicine attack and appeal to moderate political sensibilities and those who value private sector involvement.
Not single payer. What else? Framing it as a pro-business, pro-market stability plan. That sounds almost counterintuitive to some.
It might sound that way, but it makes a lot of sense. By severing the direct link between employment and health insurance risk, standardizing costs, and eliminating the administrative burden on employers.
Taking that burden off businesses.
The plan offers American businesses a far more stable and predictable operating environment. It frees companies to compete based on their core products and services, not on their ability to manage complex health benefits.
So it helps their bottom line and focus.
Yes. This framing can attract crucial support from the business community, historically a powerful opponent of reform. And finally, the narrative must reclaim the very concept of choice.
Reclaim choice. How?
The current system often offers an illusory choice between complex, restrictive insurance products with narrow networks and hidden fees. You think you have choice, but do you really?
Good point. Limited networks, surprise bills.
Exactly. The proposed reform, by contrast, offers a more meaningful choice. The freedom to see any doctor or visit any hospital in the country without fear of network restrictions or surprise bills.
Real choice of provider.
Yes. The trade-off, losing the ability to choose between confusing and often inadequate insurance plans, is framed as a clear net gain for patients, offering true freedom to seek care where and when you need it.
Okay, political strategy is crucial. Beyond the political hurdles, there are significant economic and fiscal implications to consider with such a fundamental transformation. It will obviously change how money moves in the system.
Absolutely. The proposed reform would involve a major shift in how healthcare dollars flow through the economy.
From where to where?
Moving from a system dominated by private insurance premiums and opaque out-of-pocket spending to one financed through a more explicit and predictable blend of public and private contributions.
So how would it be funded? 3 sources.
The financing structure would be built on 3 transparent sources. First, employer and employee contributions. This would be a fixed percentage payroll contribution, similar to how Social Security or Medicare taxes are structured today.
Like FICA taxes.
Exactly, providing a stable, broad funding base, replacing the variable and often escalating ESI premiums employers currently pay.
Okay, payroll contributions. Second,
income-based premiums for the AHI program, ensuring affordability for all, especially those currently struggling, with generous federal and state subsidies for the lowest income households.
making sure it's affordable based on income.
Yes, ensuring no one is priced out of essential coverage. And finally, general tax revenue, used to provide subsidies for the AHI program and support the overall stability of the system, particularly for covering the costs of the unemployed and low-income populations, much like in Japan.
Okay, so a mix of payroll, income-based premiums, and general taxes. This raises an important question. Would this actually save money overall? Expanding coverage sounds expensive.
It does, but while this is a significant shift, numerous independent economic analyses of similar universal reform proposals project that such systems would generate substantial net savings for the U.S. economy over the long term.
Substantial net savings. How is that possible?
The logic is sound. The primary drivers of these savings are the massive reduction in administrative costs from Pillar 3, remember that $500 billion in excess waste we talked about?
Right, the admin savings.
And the ability to negotiate significantly lower drug prices and provider fees through a national fee schedule from Pillar 2.
Getting control of prices.
Exactly. One analysis estimated that a universal system could lead to a 13% savings in national health expenditure, equivalent to over $450 billion annually.
$450 billion a year saved.
Potentially, this isn't just about healthcare. It's about the nation's long-term fiscal sustainability and economic competitiveness. Bending that unsustainable cost curve has profound implications for every American, every business, and our place in the global economy, freeing up resources for other critical investments.
Okay, that fiscal argument is powerful. Finally, what are the likely consequences for patients and providers during this massive transition? How can they be managed to ensure a smooth shift? Let's start with patients.
For patients, the primary benefits are clear and profound. Universal comprehensive coverage from birth to death.
No more uninsured.
The elimination of medical debt and bankruptcy as a feature of American life.
Huge relief for families.
Complete financial security against the costs of illness and the true freedom to choose any provider without network restrictions.
Sounds great. Any potential downsides or challenges for patients?
A potential challenge, particularly in the initial years of implementation, could be a temporary increase in wait times for certain elective procedures.
Why would that happen?
As millions of newly insured and underinsured individuals begin to seek care they previously postponed due to cost or lack of access, demand could temporarily outstrip the available supply of services.
A surge in demand.
Exactly. To mitigate this, the transition plan must include significant public investment in the healthcare workforce funding for medical school and nursing program expansions, incentives for providers to practice in underserved areas, ensuring capacity grows to meet demand.
So, plan for the surge, invest in the workforce.
Okay.
And for the providers, the doctors, nurses, hospitals on the front lines every day, how do they fare in this new landscape?
For providers, the reform offers a mixed, but I would argue ultimately positive ledger.
Okay, what's the good part for them?
The most significant benefit would be the liberation from the current administrative nightmare.
Freedom from paperwork.
Yes. The radical simplification of billing, the uniform fee schedule, standardized claims processing. It would allow physicians and their staff to reclaim countless hours currently lost to paperwork and devote them entirely to patient care. Payments would become stable, predictable, and prompt, reducing financial uncertainty for practices.
That sounds like a huge quality of life improvement. What are the challenges for providers?
The main challenge is they would lose the autonomy to set their own prices.
Can't charge whatever they want anymore.
Right. Reimbursement rates, while negotiated with provider input via the AHPC, would likely be lower than the highest private insurance rates today.
Lower than some top rates now.
Though they would be more stable and likely higher than current Medicaid rates. This may present a challenge for providers with very high overhead costs.
But didn't we say admin costs would plummet?
Exactly. The simultaneous and significant reduction in their administrative expenses would offset a substantial portion of this impact.
So it's a trade-off.
It is. The reform promises a fundamental trade-off. Less pricing autonomy in exchange for dramatically less bureaucracy, more stable revenue, and importantly, greater professional satisfaction by allowing them to focus on why they entered medicine in the first place. Healing patients, not battling insurance companies.
Focusing on the mission again.
Okay.
So what does this all mean for us? We've taken a deep dive into the critical condition of the U.S. healthcare system, the staggering costs, the labyrinth of access, the frustrating paradox of quality, and that suffocating bureaucracy.
A heavy diagnosis.
And we've taken a close look at the Japanese model, which truly proves that universal coverage, robust cost control, and superior health outcomes can not only coexist, but thrive alongside patient choice and private providers.
A proven alternative model.
So if we connect this to the bigger picture.
This blueprint for an American-Japanese hybrid offers a pragmatic, evidence-based path forward. It's about fundamental restructuring, not just incremental tweaks around the edges.
Not just tinkering.
No. It leverages what works exceptionally well in Japan: universal social insurance, regulated prices, administrative simplicity, and intelligently adapts it to the U.S. context, particularly strengthening primary care, an area where we sorely need improvement and investment.
And to reiterate, this isn't socialized medicine.
Not in the common understanding. It's a regulated multi-payer market that fundamentally shifts competition towards what truly matters: quality and service, away from opaque pricing and needless complexity.
Competing on the right things.
Yes. It promises economic stability for our nation, enhanced business competitiveness, and individual freedom from the crippling financial ruin of illness, a concept that is tragically alien to far too many Americans right now.
That freedom from financial ruin is huge.
The challenges to achieving this kind of transformation are immense, no doubt. Powerful vested interest will resist, and the political will required is substantial. But here's an important question for you, the listener, to consider.
Leave us with this thought.
In a country that prides itself on innovation and problem solving, in a nation that values freedom and opportunity, can we afford not to radically rethink a system that is literally costing us lives, bankrupting families, hindering our economic potential, and ultimately undermining the well-being of our citizens?
And we afford not to act.
Exactly. The cost of inaction is, in reality, far greater than the cost of bold, evidence-based reform.
Something to definitely mull over. The Deep Dive team will be back with more insights soon.